Hello, everybody. It's a great pleasure and honor for me to take part in this conference. I'm Davor Ježek. I'm working at Department of Histology and Embryology, University of Zagreb School of Medicine, and I'm also in charge for testicular tissue bank at Department for Transfusion Medicine and Transplantational Biology at University Hospital Zagreb. Today, I would like to address one burning topic, let's say, healthy aging in men and how to prevent andropausal syndrome. Andropause actually has many names, like male climacteric, male menopause, androgen decline in the aging male, the abbreviation is ADAM, or partial androgen decline in aging male, PADAM. There are some other names used by different societies like late onset hypogonadism, testosterone deficiency syndrome, androgen deficiency syndrome. The new coined, let's say, name for disease is called functional hypogonadism, and it is a coexistence of androgen deficiency-like features and low serum testosterone concentration. The community prevalence of this disease ranges from 2.1% up to 12.3%, which is the common case in most of European Union countries. The importance of testosterone, the whole story is huge. So testosterone is produced in the testis. More than 95% of testosterone come from Leydig cells that are in the interstitial compartment of testis. However, there are some other organs that are included in production of testosterone, better to say androgens, and these are adrenals. Testosterone is a rather powerful hormone. It affects skin, muscle, liver, kidney, bone marrow, bone as such, brain, and also male sexual organs. So it has really a wide spectrum of activity. The symptoms of andropause include specific symptoms, less specific symptoms, and less specific signs. Specific symptoms are, as you can see, reduced libido, decreased spontaneous erections, and erectile dysfunctions. But there are also a number of less specific syndrome and signs, and therefore it is rather difficult to put andropause as a straightforward diagnosis. It is also worth of mentioning that andropause should be treated together with menopause, so the partners should be treated as a whole, not to address one disease without the other disease. The latest recommendations for treatment of andropause came from European Academy of Andrology, which is a kind of umbrella organization addressing various in Europe, addressing various issues in health of men, like treatment of oligospermia or azoospermia or testicular biopsy, and also addressing testosterone deficiency syndrome or functional hypogonadism. The diagnosis is very difficult to establish. Actually, people mostly use various questionnaires, like a structured history taking of disease, then, of course, physical examination, and the whole spectrum of various diagnostic tools. Laboratory tools are, of course, the most prominent ones, and you can see they range from total testosterone up to prolactin levels that should be considered and carefully evaluated. This is a rather complex chart. Sorry about this busy slide, but I would like to mention to you some cut-off values of testosterone that are currently used in practice. So 12 nanomole per liter of testosterone, total testosterone, is a kind of a cutoff. If the patient has more than 12 nanomole per liter of total testosterone, it's most unlikely that some other disease, not andropause, is at stake. If the total testosterone is less than 8 nanomole per liter, sorry, then this is something that is indicating for further treatment and re-evaluation of hormones, and there is a certain gray zone between 12 and 8 nanomoles per liter where one should also consider primary hypogonadism, and one can treat these patients either with testosterone replacement therapy, or if there is a fertility at stake and the partners would like to conceive a child, then gonadotropins should be a treatment for that particular man in functional hypogonadism. Now, these are some of the important EAA recommendations that concern actually some methods of history taking, then lifestyle changes, and withdrawal or modification of drugs that interfere with testosterone levels. When the testosterone replacement therapy should start, then Academy actually recommends transdermal testosterone. It also expresses concern related to the prostate, so don't apply testosterone replacement therapy in cases of untreated prostate or breast cancer in men, of course. And when treating men above 40 years of age, one should by all means check prostate-specific androgen levels and perform digital rectal examination of the prostate. So, diagnosis of functional hypogonadism is rather difficult to put, bearing in mind the plethora of relatively non-specific symptoms. There is a pronounced role of obesity and comorbidity, as well as other medications that the patient receives. Uh, and the real clinical benefits and safety, especially in the longer term, of testosterone replacement therapy have not been fully documented, which is the major backdraw of this therapy. One should start with lifestyle changes and weight reduction as a first approach in all overweight and obese men, so don't go straight forward to testosterone replacement therapy. And also, one should consider withdrawal and modification of drugs potentially interfering with testosterone production when there are some other drugs in place. Testosterone replacement therapy is contraindicated in men with untreated prostate or breast cancer, and significant caution should be displayed when one treats men above 40 years of age. Thank you for your kind attention. This is just a view of beautiful Zagreb that was shaken by earthquake 2 months ago, but still a very nice and charming city. Thank you.